The stigmatisation through genetics is really important. My own sense, at least in Australia, is it's less than it used to be, but it's still there in our so-called advanced first world society. It is still a shameful thing to talk about.
People often think that genetics, and therefore epilepsy genetics, is black and white, like it's a yes or a no. You either have it or you don't have it. The data is easy to read and understand, right? Well, if only. It's often frustratingly, but also fascinatingly, more complex than this. We are on an exciting, accelerating journey to deepen our understandings and figure out how to help individuals and families affected by genetic epilepsies. Today, we chat with the renowned neurologist and scientist, Professor Sam Berkovic, who gives us a fab overview of just some of the new understandings. If you're new and you haven't done so already, please do like and comment on this episode and subscribe to our channel so as to get way more people learning about and understanding the epilepsies.
I'm a clinical neurologist and physician scientist. I work at the University of Melbourne here in Australia, and our work is predominantly concerned with the genetics of epilepsy.
With the genetic epilepsies, I mean, how common are they, if we could even use that word?
It's a difficult way to talk about it because every human disease is a combination of both genetic and non-genetic factors, and the same is true of epilepsy. There are some epilepsies where there are very influential genes that if you've got a change in them, you will almost certainly get an epilepsy. But for most people with epilepsy, there is a genetic component, but it's not down to a single gene that we can measure. It's so-called polygenic, and it's very likely influenced by environmental factors, most of which we currently don't understand particularly well. So we can't say of 100 people with epilepsy, so many are genetic and so many are not genetic. That's just too simple.
Could you tell us then what are the differences between inherited genetic epilepsies and de novo epilepsies? And just tell us the difference. What do those things mean?
So this is an important new concept that well, it's not that new anymore, but it's an important concept to understand that not every genetic epilepsy is familial, that it runs through a family. So before the revolution in molecular genetics, we recognised genetic epilepsies by the fact that they ran in families, that they might go through, for example, 3 generations, a grandparent or parent to a child. And those disorders definitely are genetic, and for most of them now we've nailed down what the particular gene is. But one of the new understandings has been that particularly in severe childhood epilepsies, but also in other epilepsies, you can have a genetic epilepsy without having a family history. And that's because the change in the gene or the mutation, what we call a pathogenic variant, occurs after fertilisation, that is after the sperm and the egg unite in the mother to create the child. There's no evidence in the mother or father that there is a genetic change, but it appears in the child for the first time, de novo or new. And we now know that that's a very common mechanism of severe epilepsies.
Interestingly enough, I actually know somebody from Finland who this has happened to. She has a rare genetic epilepsy, and her mum, her whole family, mum, dad, etc., were tested. They had nothing. So yeah, it really happens, right? And people seem to be quite surprised by that today.
Yeah, it's a very important new mechanism. And more than that, to go further, the sort of further development of that is what we call somatic mutations. The de novo mutation that we just talked about affects all the cells in the body of the child. A somatic mutation occurs well after fertilisation and, for example, may just affect the brain, and therefore you get a brain disease like epilepsy, whereas there is little or no trace of the change in the rest of the body. And that's even harder to detect. In epilepsy, we've detected it largely through people that have had brain surgery. So by the very nature of the detection, it's going to be in people with severe epilepsy. But this so-called somatic mosaicism is also extremely important, but harder to detect in the clinic, as you may not be able to detect it from a blood test.
I think I know a family affected by Ring 20 who were talking about this. They said that they had a similar experience where it was difficult. They had the normal genetic testing and nothing showed, and then it turned out to be somatic.
Ring 20 has its own challenges because it's not necessarily detectable on routine sequencing. You need old-style cytogenetics.
God, it just gets more and more complex, right? It's not what most people think on the outside. It can go into a lot more. So, talking about detail, I guess, how would you say genetic epilepsies, looking into them, the research into them and the understandings of them has changed or hopefully improved over the past 10 years or so?
The technology's been amazing. In terms of our ability to interrogate people's DNA for these changes, and we get new surprises basically every year. We've gone from classical cytogenetics to the ability to sequence individual genes, then the ability to sequence the whole genome or whole so-called exome in an individual, which means the genes, and now the whole genome. And we now know that there are sort of secret, tricky bits of the genome that aren't always revealed, and we've got new tricks to find them. And we'll continue to unravel newer things as literally each year. It's quite amazing how the technology is rolled out.
Have you found that international collaborations have been really valuable in this, so that we can all share work and et cetera, et cetera?
They've been essential, and individual labs can make important contributions, but by and large, the really significant discoveries have largely been made by large collaborations, and there are a number of these at the moment. There's so-called Epi25, which is winding up, which aim to sequence 25,000 people with epilepsy. We've actually exceeded that, and it's got rich yield of data. And then there's the International League Against Epilepsy Consortium on Complex Epilepsies, which looks at the so-called common variants. The exomes look at things that are relatively rare, and the common variants, which make up our so-called genetic background, are also very important. And that's been cracked open by very large numbers that we've gathered from around the world. The only big problem with those consortia is that they're largely confined to people of European ancestry, simply because that's where the samples have been and where the sort of academic strength has been. And we really want to expand it to peoples all around the world and understand the ethnic diversity in the genetic causes of epilepsy.
I agree. I think it's just so important. I mean, I live in London, a very genetically diverse city, and it's something that always quite frustrates me quite a lot, to put it politely, how, at least as you were saying, to date, it's quite a sort of basically it's a white sample, largely speaking. So to get more people involved would be fantastic. What have you found have been the impacts on families affected by genetic epilepsies? In
many, many cases, it's sort of the end of what's called the diagnostic odyssey. Everybody wants to know what's caused the epilepsy in their beautiful child who was really well and then started to develop seizures, and then it started to impact their life. And that's an incredibly frustrating thing when you don't know, and the doctors tell you don't know. And that's all we could say 20 years ago. We don't know. That knowledge, even if you can't do anything directly about it immediately, is extremely powerful information that the vast majority of families find really helpful. It enables them to then focus on the particular genetic defect in their child. It allows them to then associate on the internet with other families and share experiences, which gives them the feeling that they're not alone and they may indeed get some sort of useful tips. And there now are therapies beginning to emerge for these epilepsies. So we hope the game will change even more in the next few decades.
So when we talk about, this can apply to epilepsy as a whole, but I think particularly with identified genetic epilepsies, in some cultures, people can feel almost like, okay, I can't tell anyone, I have to be ashamed of this, nobody is going to marry my child or anybody else in my family, etc., etc. What are your experiences when it comes to that?
The stigmatisation through genetics is really important. My own sense, at least in Australia, is it's less than it used to be, but it's still there in our so-called advanced first world society. It is still a shameful thing to talk about. It's even worse in some other societies where, as you say, there are prohibitions or social prohibitions in marrying into a family with somebody with epilepsy or marrying a person with epilepsy. So these things are terrible. They are slowly being worked back, I think, but it remains a problem. And historically, I think it was definitely even worse. Very little in genetics was done after the Second World War until the 70s and 80s, and I think this was still a hangover from the eugenics period. Where you just couldn't talk about this. That is certainly, I sense that is certainly better through my career, but it's still a problem and still a big problem.
Yeah, I mean, I've spoken with many people in countries such as like India or parts of like the African continent, particularly, but even with people actually in the UK, who have been so unknowledgeable about the epilepsies. A lady the other day, I couldn't believe it. She asked me if epilepsy was catching, and no, it's not. It's really not. So I think we've got a lot to do, but like you say, we've come so far. Like in my lifespan, it's just beautifully shocking how far we have come. And I see that speeding up now. Would you agree? Like things are really kind of taking off.
No, it is. I agree.
Could you tell us what you think the future holds for the next, I don't know, like 5, 10, 15 years for epilepsy research, and then being able to implement new things that we've learnt into, I was going to say treatment, but also potentially prevention as well of development of the epilepsies?
So I'd be hopeful in that time frame we get a really good understanding of what we call the genetic architecture of epilepsy. That is, in an individual patient or more broadly in a group of patients with the same type of epilepsy, exactly what are the genetic contributions to the epilepsies, what we call rare variants that have a large effect, and the so-called common variants that contribute to the background. And we're getting closer to that aim. That aim would have seemed unachievable 15 or 20 years ago. I think we're close to that. There is, of course, the very important aim of applying that to therapy in what we call precision medicine, that if you know what the actual genetic basis is, you should be able to get treatment that targets that. I think most people agree that that's gone a little slower than many of us would have hoped. We began talking about this 8-10 years ago in a very serious way and thought it would be a much quicker course. It is proving more difficult, but I am hopeful that the game will change for that, and that we will be able to see a person in the clinic figure out what the genetic causes of their epilepsy is, and then give them a therapy that directly targets the fundamental abnormality. And I think there are quite a few steps that have to happen before that becomes a common experience. It's happening occasionally, but it's still not a common experience. It hasn't happened as fast as we initially had hoped.
So I'm just thinking, like, for instance, there are some genetic epilepsies more commonly known as, like, say, Dravet or like, I don't know, SCN2A8A, for instance. What about for people who say they have what is more commonly known as a temporal lobe epilepsy. They don't know the cause, but it could it potentially be, do you think, identified in the future, the genetic components that may have contributed to a more common epilepsy, such as temporal lobe epilepsy? But it could be anything, rather than the more commonly this epilepsy is solely down to this one gene.
So you've highlighted the divide between so-called monogenic or single gene epilepsies and complex epilepsies, by which we mean they're due to a combination of genes. And temporal lobe epilepsy is a good example. We've been working for many years on so-called familial temporal lobe epilepsy, where it runs in families, but it's not, for the most part, due to a single gene. It's due to multiple genes and in what we call a polygenic architecture. And we're now well on the way to tracking that down, but there's still a way to go. So I'm hopeful we will do that. And the other big group is, of course, what is variously called the idiopathic generalised epilepsies or the genetic generalised epilepsies, where again, for the most part, you don't see a single gene, but it's due to multiple genes. And we're hopeful we already do have a somewhat better understanding of that, but that's also got a long way to go.
Thank you to Sam for giving us a brilliant overview of where we are regarding our knowledge of, our understanding of, and our hope for the future for those affected by the genetic epilepsies, which is heaps more than previously thought. Check out more about Sam and his work on the website torierobinson.com, where you can access this podcast, the video, and the transcription of this entire episode all in one place. And if you're new and you haven't done so already, please do like and comment on this episode. Subscribe to our channel so as to get more people learning about the epilepsies. See you next week.